Hi, thanks for tuning in. My name is Gannon Yu. I am a PGY3 in internal medicine. I originally did my training at UBC, and I'm currently a resident at University of Calgary. In today's video, we'll go over antibiotics, and so an overview of antibiotics with a focus on inpatient medicine, as well as what you might commonly see and need to know on an internal medicine ward. For each of the antibiotics, we'll talk about the classes and mechanisms of action, as well as coverage, so gram-positive, gram-negative, or anaerobic coverage for each of the antibiotics, and common uses and clinical indications for the antibiotics, as well as common side effects. Okay, so we'll start by talking about cell wall synthesis inhibitors. And the first drug or family we'll talk about is the Penicillin family. So to start, we have Penicillin V, and that covers gram-positive organisms. Mostly we use it for strep, so group A strep pharyngitis. Penicillin V is a oral medication. More commonly on internal medicine, you'll see Penicillin G. And so again, it's gram-positive coverage. We often use it for invasive strep infections, so group A strep, group B strep, bacteremia, septic arthritis, osteomyelitis, and neurosyphilis. Of course, in all these cases, the bug that grows has to be susceptible to penicillin, and in those cases we use Penicillin G, which is IV. Next, Benzathine Penicillin. This is an intramuscular form of penicillin that is used for primary and secondary syphilis. Cloxacillin is an important drug to know. For Staph aureus, more than 85% of it is resistant to regular penicillin, and so we use cloxacillin in the case of MSSA confirmed infections. MSSA stands for methicillin-sensitive Staph aureus. So in the scenario of bacteremia, endocarditis, septic arthritis, osteomyelitis, and pneumonia, if it's MSSA, that's the bacteria, then we use cloxacillin. And I'm referring to the IV form. There is an oral form of clox, but it's uncommonly used in hospital for these indications. Cloxacillin is a relatively narrow spectrum medication, so we try to put patients on it when that's appropriate. Next family is the Amino Penicillins, which includes ampicillin and amoxicillin. So ampicillin is for gram-positive coverage of susceptible streptococci, enterococci, and listeria. It can be used in the case of invasive infections such as bacteremia and meningitis, so it's often used as empiric treatment for listeria suspected meningitis, and it is an IV medication. Amoxicillin is really commonly seen. It has similar coverage to ampicillin, so the gram-positive coverage includes strep, enterococci, and listeria. It's used often for sinusitis, for otitis media, for URTIs, so less severe infections. It is an oral medication. When amoxicillin is combined with clavulanic acid, we call that clavulin, and this is very broad spectrum. So it covers the same gram-positive, so strep, including strep pneumo. It covers enterococcus, that's susceptible, and also a bit of MSSA coverage as well as listeria. And it has quite significant gram-negative coverage, so things like E. coli, Klebsiella, those are all covered, as well as some anaerobes, so oral anaerobes plus also Bacteroides fragilis as well. So clavulin has a broad coverage, which makes it good for dental infections, for pulmonary infections, and complicated wounds and bites. And clavulin is a common step down from piptazole, which we'll talk about next. However, it does not provide Pseudomonas coverage. So next one is piperacillin, and we use it as piptazole, so it's the combination of piperacillin plus tazobactam. This one is good for gram-positives. For gram-negatives, it covers anaerobes as well as Pseudomonas. So piptazole is used often when you have an unknown infection source, in the case of sepsis, for empiric therapy. It's used for intra-abdominal infections, for nosocomial infections as well. Of note, piperacillin tazobactam does cover enterococci when it is sensitive to ampicillin. And the last one here we have is under the monobactam family. It's called aztreonam, and it strictly covers gram-negative organisms. We don't see this used very much, but it's worth noting that it can be used in penicillin allergic patients. Now, penicillins, the most common side effect is definitely going to be an allergy. It's worth asking the patient what their specific allergy was. In the case of anaphylaxis, it'd be best not to give anything related to penicillin if it's a true allergy. Of course, if it is required that they be treated with some sort of penicillin, they may warrant penicillin desensitization therapy. Other more common side effects, so there can be rash, there can be Stevens-Johnson syndrome, as well as a acute interstitial nephritis. Okay, so moving on from the penicillin family, we have cephalosporins. So the cephalosporins can be split up into generations from 1 to 5. And the first generation is a really common medication class. So Keflex is the PO form, as well as Ancef is the IV form of the first gen cephalosporins. We commonly use these for skin infections and cellulitis, and as well Ancef is used for pre-op infection prophylaxis. And the coverage, it covers MSSA, so staph, as well as most streptococcal species. Moving on to the second generation, you have Cefuroxime, which is available IV or PO. And in these cases, as you go from first, second to third to fourth gen, you do get more gram-negative coverage, and you do lose gram-positive coverage as a trend. So Cefuroxime, you do get some more gram-negative coverage, and the mnemonic here is the PEC hen, so you can get Proteus, E. coli, Klebsiella coverage, as well as Haemophilus influenza, Enterobacter, but not all the species, and Neisseria. And there is a subgroup of the second-gen cephalosporins that may not be too commonly used on internal medicine, but it's worth knowing. There's cefotetan and cefoxetin, and specifically these two drugs, they gain additional coverage for Neisseria and also anaerobes, specifically Bacteroides fragilis. So that's why it's commonly used for intra-abdominal infections, for PID, and also post-obstetrical surgeries. So you may see that if you're on a consultation service for the obstetrics side of things. Next is the third gen cephalosporins. So Ceftriaxone is really commonly used on internal. It's available IV or IM, but we most commonly see the IV form. It does provide great gram-negative coverage. It has some gram-positive coverage for Streptococcus, as well as some Staph aureus, MSSA. However, it's not really preferred as the choice for MSSA, as it is still a very broad antibiotic. Ceftriaxone does penetrate the blood-brain barrier at high doses, so the empiric meningitis dosing is often 2 grams IV Q12 hours. And it's also used for things like community-acquired pneumonia and pyelonephritis as well. Another third-gen cephalosporin, ceftazidime, is worth knowing because it does cover Pseudomonas, and you may see ceftazidime used as a febrile neutropenia agent. And an oral third-gen cephalosporin is Cefuroxime, and this is strictly used for the case of Neisseria gonorrhea that is sensitive. Fourth gen, we have Cefepime, so it's an IV fourth generation cephalosporin that has broad gram-positive and gram-negative coverage and covers Pseudomonas as well. However, it does cover less anaerobes than Piptazo does, and cefepime is often used for serious nosocomial infections. Then we have the 5th gen. The drug to know here is ceftaroline, not commonly used at this time, but worth noting that ceftaroline does have MRSA coverage. So as a group, the cephalosporins, there is some cross-reactivity because the cephalosporins are derived from the penicillins beta-lactam ring. So if the patient has a true penicillin allergy, you do need to be careful with the cephalosporins. Another note is that patients can be allergic to a specific cephalosporin, but not the entire class of cephalosporins, because the allergies that you get from cephalosporins is specific to the side chain of the medication. Okay, so moving on to the next group, we have the Carbapenems. So the Carbapenems are a group of antibiotics that provide really broad coverage, so gram-positives, gram-negatives, anaerobes, as well as resistant organisms. So there can be organisms that have ESBL, or extended spectrum beta-lactamase resistance, as well as AMP-C resistance, and these are sort of tougher to treat bacteria that the Carbapenems do treat. So in this family, we have 3 medications. We have imipenem, which is the older form. It's the worst of the 3 for lowering seizure threshold. So if the patient does have a seizure disorder, it's worth thinking about this. Imipenem does have the best enterococcal coverage of the 3. Another one would be ertapenem. This is commonly used as an outpatient if they need outpatient IV therapy because it's easy, it's once a day dosing. However, ertapenem does not have any Pseudomonas coverage. Meropenem is the common one you'll see that is used as an inpatient. It does have Pseudomonas coverage. And so that's probably all you need to know about the Carbapenems. And moving on, glycopeptides. So in this family, we have vancomycin, which is really commonly used as an inpatient. It is a bacteriostatic antibiotic that strictly covers gram-positive organisms, and we especially use it in the case of MRSA, so methicillin-resistant Staph aureus. Vancomycin is used as empiric treatment in meningitis, and it's specifically not for MRSA, but it's actually for penicillin-resistant strep pneumo. Vancomycin is also used orally, but only in the case of C. difficile infection. And back to the IV form, vancomycin does exhibit what we call concentration-dependent killing, and because of that different pharmacokinetic property, we do have to measure trough levels. So the level is often taken an hour before the dose is given, but our target trough levels are typically 10 to 15, or in more invasive MRSA infections, we target a trough level of about 15 to 20. However, the evidence for this is not very strong. For vancomycin, side effects, so renal toxicity is definitely a concern here. As well, red man syndrome is something that can occur. This is when it's an infusion-related side effect where you actually get redness and a rash, usually from the neck up, so really involving the face, but not below that, and it's due to rate-related histamine release. If the patient does have evidence of red man syndrome, you can stop the infusion and you can resume the vancomycin at a slower rate. Alright, so that finishes up the cell wall synthesis inhibitors. We went over the penicillins, cephalosporins, carbapenems, and then the glycopeptides. So we're going to move on to this group here, the protein synthesis inhibitors. And 30S and 50S refers to the ribosomal subunit that the antibiotic targets. So within the 30S subunit family, we have to start off with is the aminoglycoside family. So in the aminoglycosides, we have gentamicin, tobramycin, and amikacin. And aminoglycosides only target gram-negative bacteria, including Pseudomonas. Common side effects, you have nephrotoxicity, ototoxicity, as well as vestibulotoxicity. Aminoglycosides have a concentration-dependent killing and a significant post-antibiotic effect. So I won't go into those right now, but it's worth looking up if you're going to give an aminoglycoside, because the pharmacokinetics are different. You need to dose them differently and monitor them differently as well. So that's aminoglycosides. Then we have tetracyclines. So the most common tetracycline that we'll see used is doxycycline. The other alternatives, we have tetracycline and minocycline as well. It's worth knowing some of the side effects, so we never give it to children because it is somewhat teratogenic. It inhibits their bone and tooth growth. There is incidence of photosensitivity, as well as pill esophagitis, and it does interact with dairy foods as well. Doxycycline is often used because it is an oral agent that does cover some community-acquired MRSA strains. Tetracyclines are actually a pretty broad spectrum drug, but often we use it in the case of bacteria that have atypical cell walls, for intracellular infections as well. So we'll give it for things like mycoplasma, for chlamydia, for spirochetes, for rickettsia, and a lot of other sort of more unique infections. Okay, moving on to the 50S side, we have macrolides. So the common ones to know here are erythromycin, although we hardly ever use erythromycin anymore. There is a significant incidence of GI intolerance, some nausea, and increased gastric motility. There's clarithromycin as well. We don't use this very much for inpatients as well. There have been some studies that show that in the case of pneumonia, that patients that have cardiovascular disease do poorly. They have worse outcomes and mortality when they're given clarithromycin. Azithromycin, however, is very common. We often will use it for atypical coverage for community-acquired pneumonia. Specifically, we use it to treat mycoplasma, chlamydia, pneumonia as well. And it does provide some gram-positive coverage, especially strep pneumo. It does have some gram-negative as well, such as Haemophilus influenza, Moraxella, Legionella, and H. pylori. So we'll often use these for community-acquired pneumonia, for respiratory infections, for sinusitis, and otitis media. The next group is lincosamides. So this includes the medication clindamycin, and this is a bacteriostatic antibiotic that has very good bioavailability. So giving it oral is just as good as giving it IV, essentially. It has gram-positive coverage. It has some anaerobic coverage, as well as covering MRSA as well. Clindamycin can often be used for cellulitis, for abscesses, and for dental infections. And a really common problem with clindamycin is that you can get very high rates of C. difficile diarrhea. Last one here for the 50S antibiotics, we have the oxazolidinones, and this includes linezolid. So this is available both PO and IV. It is a bacteriostatic antibiotic that really only covers gram-positive organisms. So it's used in the case of staph, MRSA, coagulase-negative staph, that's the cons here, Enterococcus, and VRE. So it's a really good antibiotic that covers gram-positives. We often will use it for MRSA and VRE infections, like skin, soft tissue, urinary infections, and pulmonary infections. However, a common side effect with linezolid is actually some bone marrow suppression. do have to monitor their blood work while they're on this medication, and it often is limited to infectious disease use only. Okay, that finishes off the protein synthesis inhibitors, and so our last one is the miscellaneous classes. So we'll start off with the lipopeptides. This is a cell membrane disruptor, and the specific one to know is daptomycin. Again, daptomycin, just like linezolid, is really just for gram-positive organisms. We use it to treat MRSA, for VRE, for bacteremia, for right-sided endocarditis specifically. It is used in the case of vancomycin in intolerant patients, or sometimes patients are really hard to actually get into the therapeutic range for vancomycin, and we may use daptomycin in these cases. It's worth noting that daptomycin is deactivated by surfactant, so it isn't used for primary pulmonary infections. And a side effect can be rhabdomyolysis, so they do need to have their CK monitored weekly at least. Next is the DNA gyrase inhibitors, including the class of quinolones. So these are really common medications that we use. Ciprofloxacin, it's oral or IV, but we often will only use the oral form. The bioavailability is quite good, so we try not to use IV when we don't have to. Cipro is the only oral agent that covers Pseudomonas, and this is really important. It also provides pretty broad gram-negative coverage. So things like E. coli and Klebsiella are covered by this. And we use Cipro empirically for UTIs, for intra-abdominal infections. However, in those cases, we often will combine Cipro with Flagyl as well. Next, we have the respiratory fluoroquinolones. So levofloxacin and moxifloxacin are included here. They're different from Cipro in that they have some gram-positive coverage, including strep pneumo as well as the atypicals as well. They don't have any effective Pseudomonas coverage, and we often will use these for community-acquired pneumonia. Side effects for quinolones, we have possible tendon rupture, hepatitis, and also you can have worsening of your prolonged QT, psychosis, as well as Stevens-Johnson syndrome has been reported with quinolones. And moving on to metabolics, so in this class we have Septra, so that stands for sulfamethoxazole trimethoprim. And the mechanism here is that it blocks the synthesis of folic acid, which is needed for bacterial DNA replication. Septra will often be used to cover gram-negative organisms in the case of UTI or prostatic infections. It also does cover MRSA. And Septra, it's worth knowing the side effects. So hepatitis can be an allergy, kidney dysfunction, Stevens-Johnson syndrome, as well as hyperkalemia. Moving on, here is agents that sort of disrupt bacterial DNA. Number one, we have nitrofurantoin or macrolide, and this is really just used for UTIs, lower UTIs, and simple cystitis. It does cover common organisms such as E. coli and Enterococcus, but the use is limited to simple UTIs. And a side effect to know is that specifically nitrofurantoin can cause nitrofurantoin lung, which is a specific type of interstitial lung disease. So that should be on your differential for ILD. And lastly, we have metronidazole. This is a commonly used medication, used both oral and IV. It is bactericidal. It has a good anaerobic coverage. It can be used for C. difficile, but in those cases it is only used in the oral form. It's used for intra-abdominal anaerobic coverage, specifically for Bacteroides fragilis and GI infections. A common side effect or reaction is the disulfiram reaction. So in these patients that are started on Flagyl, you have to make sure that they do not have co-ingestion with alcohol, because they'll have very significant GI symptoms and intolerance to this. It also covers Giardia as well. Okay, and that finishes off the video. So we've talked about different classes of antibiotics and a lot of details about each one of the antibiotics. So I hope that was helpful. Please send me an email if you have any feedback or suggestions on what sort of videos I should do next. And please feel free to like and subscribe my channel. Hopefully I'll be making some more of these videos soon. Thanks for watching.